I'll walk you through a bit of the rubric I use when I approach patients in terms of trying to figure out the diagnosis and therefore the effective treatment strategy. LDDF is akin to what I learned from, I believe it was Mark Miller, but I'm not sure exactly where this idea originated from in terms of like funneling down a patient's diagnosis and care. But what I originally learned was LCDF, so location, classification, direction, force. But I personally don't like the word classification. I think we can be confident in using the word diagnosis. I don't think patients understand what classification means. I don't think it's a consistent word used throughout medicine. So I'm comfortable using the word diagnosis. I think people are more likely to think of a diagnosis as an anatomical lesion, a bone fracture, for example. But we also have pathophysiology. We also have physiological problems, and I think those problems can be correctly called diagnoses as well. I just think people are more likely to call them syndromes or classifications, and I prefer to use the word diagnosis, just a personal thing of mine. But I spent 5 months working in Tallahassee at Mark Miller and Chad Gray's clinic, IMC, as part of my mentorship journey, learning MDT, because they have a group of about 13 or so clinicians who are all very highly trained at using MDT or repeated movement testing as the main part of their orthopedic care. And so I wanted to be around that group of clinicians and really kind of hone my skills in MDT. But of course, not all patients have joint derangements. We're trying to figure out the most effective way possible. If patients do, and if they don't, what else is the diagnosis and what's the effective care for that person? So let's start with LDDF. L is location. And I think that can sound simplistic, but when it comes to orthopedics, we really need to understand where the problem is coming from. If a patient has raging nerve pain from the low back to the foot, the person and the clinician often intuit that that foot pain is coming from the low back. But say it's just foot pain, or just anterior knee pain, or just lateral thigh pain. That can also be from the low back. So this absence of understanding referred symptoms in my mind is one of the top 3 problems with orthopedics right now, is that we're not even getting the location right. And I've seen patients post-surgically that were not fixed, and I would propose to the patient subtly or without words that the patient's problem was not coming from the location that was surgically changed. So location can take a few tests to figure out, right? And the problem with repeated movement testing compared to other quick tests is it takes a little time and it takes an understanding. And I say the word problem lightly because it's not really a problem. It's just how the testing operates. So in my experience, the hardest problem to suss out in terms of location is these kind of vague symptoms that are low back-ish, buttock, lateral hip, thigh, because there are so many different locations that can create those symptoms. And so for me, those take a little bit more time in several cases, or in many cases, to really get to the actual location of the source of the root cause. So first things first, find the location. Second, once you found the location, what's the diagnosis? I argue that at least 85% of diagnoses are going to be mechanical joint derangements or tendinopathies, which are basically mechanical tendon problems, meaning that they're structurally competent, but they're not functioning well. The joint is competent, it's just not moving well. The tendon's competent, it's just not functioning well. If I test patients with tendinopathies, they can often do the work. It's just painful. And so tendinopathies have a very specific intervention, as do joint derangements. So there are other diagnoses in orthopedics, of course, but I want people to be sure that when they think about orthopedic diagnoses, they're not just thinking about orthopedic complaints, because those are 2 distinct entities. Knee pain from Lyme disease is not an orthopedic disorder. It's an infection that's causing an orthopedic complaint. Same with other autoimmune disorders causing musculoskeletal complaints, or other issues, like if arthritis is coming from insulin resistance, or if arthritis is coming from a reaction to a food trigger, or if people have diffuse pain because of environmental toxins. So we need to separate, in my mind, between orthopedic diagnoses and orthopedic complaints, because not all complaints are coming from a musculoskeletal problem. So the other bucket, if I said that 85% are those, are going to be mostly structural lesions. I mean, yes, you have the rare frozen shoulder and kind of other musculoskeletal disorders that are, few and far between. We can get into a separate discussion about whether frozen shoulder is what's the underlying cause. We know risk factors include thyroid disorders and insulin resistance. But the other main bucket is structural lesions, true ligament tears, true muscle tears. I have a big hole in my quadriceps. I know that muscle tears exist. Bone fractures, true disc herniations that are structural, cannot be fixed with movement and time, or movement and in a quick amount of time, and therefore need either a protracted amount of time to get better with an environment for healing or surgical interventions. But just because it's a structure is affected doesn't mean it's not able to be fixed physiologically, basically, with movement. So those two, joints and tendons, make up the bulk of things. And so if we think of those two in particular, then we kind of go on to this part of the rubric, which is direction. So taking joints and tendons, I'm looking for the direction that problem needs. And when it comes to a joint derangement, I'm thinking, does that joint need flexion? Does the joint need right side glide? Does the joint need left rotation? And more specifically, does it need it in weight bearing or non-weight bearing? Does it need it in supine or prone? So we have to be more deliberate and specific when we're thinking about direction. It's not as simple as flexion. And when it comes to a joint tendinopathy that we're rehabilitating with provocative movement repeatedly throughout the day as well, starting with a lesser load usually, we are also looking for the direction that reproduces the familiar pain. So in the case of an elbow tendinopathy, is it wrist extension with the elbow extended? Is it wrist extension with the elbow bent? Is it the wrist extended with a grip or with a little supination, etc.? I'm looking for the direction that reproduces that tendon's pain, which is a separate thought process than with how to treat a joint derangement. Then we're looking at force. So going back to joint derangements, I've talked about the 5 levels of force progression. How much force does this joint need? We're going to progress force in a safe and appropriate manner, but sometimes we need the highest level of force. Most times, patients can self-treat with just their own generated forces with some overpressure that they can provide. But sometimes getting in there with mobilization is needed for short-term effects. When it comes to the tendinopathy, we're thinking, does it need 2 pounds of load? Does it need isometrics? Does it need 5 pounds of eccentric load? The main thought process for the tendinopathy, again, is how to reproduce that familiar pain. And I'm telling patients I usually want it to be about a 6 out of 10 on the pain scale. And as soon as it starts to drop, we need to up the weight or up the dosage in the set, whatever we need to do to keep it to be still moderately provocative. So this is how I'm thinking. And again, it can take a while to go through these with your testing, but that ensures that you're getting the right diagnosis, because if you start off with the wrong treatment, then you just got to go back and start from the beginning as well. So this is how my mind is operating when I'm thinking about a patient. And if I get down here and I start looking at things and they're not going like I think they should, I have to jump back and start to ask myself, do I have the right location? Is this really a hip joint, or is it the low back or the SI? Or is this really the wrist, or is it actually cervical or thoracic or elbow or shoulder in rarer cases? But for people who are using repeated movement testing with joint derangements, this is indispensable. I would say it also kind of applies to the tendinopathies of the world. It doesn't apply so much to the person had a fibular fracture, they had surgery, now they're presenting to me, and the diagnosis that I've gleaned from an evaluation is this is post-surgical, it's post-trauma, because the surgery was trauma, and therefore it's not going to be one motion that's rehabilitating this person. It's going to be restoring range of motion, restoring strength, restoring proprioception, balance, function, etc. It's more kind of predictable. But if you're thinking, I think this joint is deranged from being immobilized, or I think something else has happened, as a clinician, we have to figure that out. And if it is more specific like that, then we're kind of going through this algorithm as well. But for clinicians who are starting to use repeated movement testing, I think this is really helpful when you're starting to learn it. It becomes second nature. But the biggest kind of takeaway is that you really gotta pinpoint the location first. And I think this lack of understanding of referred symptoms is a huge problem. So be confident in the location before you start to fiddle around with the rest.